Hi, good evening, everyone. I'm Anvesha Pandey, Deputy Director at NAT Health, and I'm so excited to be back again to cover another aspect of Ayushman Bharat Digital Mission webinar series. This series is organized jointly by NAT Health and NHA, and we have been running this series since November, and almost every week we have an eminent speaker come on this platform and share their insights on one of the aspects of ABDM. We've already covered many of the areas like on insurance, design and architecture, etc. And today we will be discussing how can common citizens use and benefit from the ABDM ecosystem. And we have with us Dr. Ajay Bakshi, who's a neurosurgeon, tech entrepreneur, and advisor at NHA. He has been at leadership positions at Max Hospital, Manipal Hospital, and Parkway Hospitals, and has also been with McKinsey at their New Jersey office. He's the co-founder of Neurons AI, which is building technology products by converging neuroscience with artificial intelligence. He's also a volunteer at iSpirit, a Bangalore-based technology think tank. Dr. Bakshi is very passionate about using technology for solving population-scale problems. He has led the development of the conceptual model underpinning the Unified Health Interface, UHI, which is being implemented by the NHA. A very warm welcome to you, sir. We also have with us Dr. Pankaj Talreja, a master teacher trained at ISB Hyderabad. He's a professor at the International Institute of Health Management Research at New Delhi and has been associated with various national health programs. He's very passionate about health systems, engineering, and healthcare financing. Welcome, Dr. Pankaj. And I now request both Dr. Talreja and Dr. Bakshi to kindly take this discussion forward.
Thank you.
Thank you, Anvesha. So it's been a pleasure being here, and thank you for having me. And I'm here as a layman, probably would try to learn a lot about this ABDM ecosystem from Dr. Bakshi. I'm really very excited about it. So a few fun facts before we start. ABDM, it was launched on 27th September, and today is 27th January. So it has been exactly 4 months now. And when it was launched, Ayushman Bharat PMJ per se was around 3 years old, and the exact words which were used was that it is Arogya Manthan amongst this ecosystem, right? So those were the words used. So before we can actually go to that, how can citizens use and benefit from it? I would request Dr. Bakshi to let us know what this ABDM ecosystem per se is. So if you could briefly, sir, just let us know what are we talking about here? What is this ABDM ecosystem?
So no, thanks for inviting me to this wonderful session that Nat Health and NHA is organizing. I think it's very important that there be a public dialogue and everybody participates in this, because essentially ABDM is a public good. It's a digital public good. What is a public good? A public good is a thing that is used by all citizens and improves the lives of all citizens, and not supplied or supported by a private company. So a road is a public good, electricity is a public good, water is a public good. These are all public goods that are there, but these are analog public goods. These are not digital public goods. I think the best example of a digital public good is the UPI, the Unified Payment Interface, which has transformed the lives of most Indians. I struggle nowadays to find an Indian who has not used some form of UPI payment, either to send money or to receive money. And then I think that is a good analogy to talk about when you ask Dr. Pankaj, what is ABDM? ABDM is a digital public good that is at the very early days of its inception. It has been launched, but what the launch involved was the launch of the building of it. The launch is not yet of the fully fledged implementation of it, because you will realize that UPI was launched in 2016, and then the real citizen benefits really started happening in 2019, 2020 onwards. So it takes a few years before all the participants get to contribute, get to know what these public goods are, and also get to customize them and build their own solutions on top of this, right? So to come to the crux of your question, Ayushman Bharat Digital Mission is the launch of a journey which will use digital technologies to make the lives of citizens better from a healthcare point of view, right? And then now we can discuss deeper as to how that will happen. But it's so the two points I want to make is it's the start of a journey. It's a collaborative journey with all citizens, stakeholders, companies, government agencies, NGOs. Everybody has to come together to contribute and actively shape this platform, because this is of the citizens for the citizens. And it is going to be transformative, because by design, and you talked about the conceptual design, by design, we have studied very carefully all the mistakes that have been made in the, say, the Western healthcare system, which has become very expensive and is not very effective for the amount of money that they spend. And the conceptual model here has been designed in such a way that it actually leapfrogs India into a very modern digital health ecosystem, which does not exist anywhere in the world. And we can go more into details of what that would look like.
Okay, but typically, sir, healthcare system generally has a three-party thing to it, right? One would be the user at the end of the day, the person who's actually using the healthcare system.
Yeah.
The other would be the provider.
Yeah.
And the third party would probably be the payer, right?
Yeah.
It could be an insurance company or it could be the government, right? So it's typically, like you said, in UPI, it is generally somebody is getting the service and paying for it. It's usually two party. Here, probably we are actually talking about three parties. So how do you see this arrangement working between government, the citizens per se, and the healthcare providers? How do you see this happening?
No, that's a great question. So if we go rewind back, say 10, 15 years, these three parties were working essentially on paper. So I will go to a hospital, the hospital will ask me, what is your disease? They'll diagnose me, they'll do the test. And then at the end of the whole episode, they will either give me a discharge summary, and I'll either pay out of cash, or if I have some, we used to call it Mediclaim in those days, the early Mediclaim insurance, then I will pay the money and I'll send a reimbursement to my insurance company, right? So that is how the three parties used to interact, say in early 2000s. Now, what has changed is, and actually USA and Europe are far ahead of this journey from us, is that essentially what binds these three parties together is the data of the patient, right? What is the patient symptom? What was the diagnosis? What was the procedure? What was the billing? How much was claimed? How much was paid? It's all data, essentially, right? So what is now possible, which was not possible 15 years ago, is to have all these players, the three stakeholders that you're talking about, use a common platform for data, so that for the citizen, it is not a hassle that he has to carry a lot of paper, he's forgotten some reports, he has to pay cash out of his pocket and wait for the reimbursement to come through, he has to answer hundreds of questions. So a lot of efficiency improvements can happen if you combine a platform where any hospital, any insurance company, any citizen, any doctor can plug into that data with the consent of the patient to, dramatically improve the efficiency of the transaction that you talked about. I would actually point out that there is also another transaction, which is even more important to some extent, which is the outpatient transaction. And you will know, as you are a health system thinker, that almost 90% of healthcare is outpatient, right? I mean, typically admission happens 5%, 6%. If I see 100 patients in an OPD, not more than 4 or 5 of them need admission. The remaining 90, 95, I can manage as a doctor with my outpatient. So now let's talk about that interaction for a minute. You will agree with me that in India, there is almost no outpatient insurance, right? Because of the simple fact that these inefficiencies that we talked about, the cost of a claims processing today is upwards of 600-700 rupees for any insurance company, even the most efficient insurance company in India, right? And the typical outpatient bill is 400 rupees, 300 rupees. So how will you process a claim and spend 600 rupees to reimburse somebody 300 rupees, 400 rupees? So actually one of the objectives of this whole infrastructure is that the cost of processing a claim should come down to 5 rupees, 10 rupees through automation, through digitization. And actually we have seen that story play out before when KYC in, say, even 10 years ago, know your customer documentation used to cost a telecom company upwards of 60, 70 rupees. And now with Aadhaar based identification and eKYC being launched again as a digital public good, the cost of KYC has come down to, I believe the latest number is 4 rupees, 5 rupees. And that allowed telecom to penetrate deep into India. And now every Indian has a cell phone, pretty much, right? So I think that is the magic that these digital efficiencies can bring. And we have as a country seen those being delivered. And the ambition is that we do something similar in healthcare.
Okay. So we have touched upon a lot of things here, and let me just decipher it for a moment, right? So when you were actually talking about KYC and Aadhaar, I remember 2014, there was a Delhi Economics Conclave, and we were talking about Jan Dhan accounts, Aadhaar, and mobile telephony, which probably got interlinked, and then probably this KYC, the cost could come down. Yes. But initially itself also, with Aadhaar being adopted, there was a lot of hue and cry regarding this data, right? And then Supreme Court had to intervene probably, and Aadhaar was not made mandatory. A lot of those issues came in. So probably we are going, what I could understand from you was that probably we're going through that same journey. So with Aadhaar also data challenges were there. Don't we see that those kind of data challenges with this digital mission?
Yeah, no,
and this being much more sensitive data. Health data is always considered as more sensitive.
Yes, no, it's a great question, and I want to even rewind back to some of us who had emails in say early 2000s, and there used to be something called a very famous Nigerian email scam. You will get an email from some uncle in Nigeria who's died and left you $1 million, and they say, give me your bank account and I will send the money to your bank account. And the scam was that just with the bank account details, they could somehow magically suck out money from your bank account. You remember that, right? So that was a very well-known scam. It is still, if somebody Googles it, they can read about it. Now, fast forward to today, when I can, just with your phone number, I can send you money, 10 rupees, to 1 lakh rupees or maybe even more, right? Now, how has that trust been built? I don't know you in person. For all you know, I might be a scamster, you might be a scamster. But this Aadhaar, the jam trinity that you talked about, the Jan Dhan, the Aadhaar, and the mobile, that has built that trust in which I can now buy a banana, I can buy an Amazon good, I can pay a tip to my Zomato delivery person. So that is how this thinking has evolved from the experience of Jan Dhan, Aadhaar, and mobile, which is now making us confident that yes, it is possible to do it in healthcare also. And I'll come to that point, what you said about the sensitivity. Just give me 1 minute to talk about something very important. See, the reason why that was, there was a lot of halla-gulla at that time, because that model of citizen-centric data did not exist anywhere in the world. And actually, Mr. Nandan Nilekani has written a very powerful foreign affairs article. It is there on Google. In 2017 or 2018, he wrote that, where he talks about the Indian citizen-centric model of data, which actually does not exist in the US, because in the US, the data belongs to a large company, whoever is helped create that data, whether it's Facebook, whether it's a healthcare data company. Then there is a second model in China where the data belongs to the government. And we have seen how strongly the government has actually used it for the benefits of citizens, but the citizens have no right over their data. The government can take what it wants and use it for whatever purpose it wants, right? So that's the Chinese model. Then there is a third European model, which was put in place with this passing of GDPR, which is a very stringent model. And in effect, it means that almost nobody can do anything with data. And the consequence of that is that there are no large tech companies in Europe for the last 20 years. Because the whole game is about data. And if you have put rules which basically say, no, you can't touch, you can't read, you can't cut, you can't do anything, you can't build innovative models, then Europe is actually lagging behind. And Europe is also realizing that, and there is a movement in Europe to actually adopt the Indian model. And what is the Indian model? The Indian model is make the citizen own and control his data. That is what happens when ICICI Bank sends, or if I buy something from a shop, Paytm sends me that, are you confirming the consent to buy this? That means I am confirming to Paytm that please transfer X money from this account to the shopkeeper's account. So I am in control. I can say, no, I don't consent to it. Or I can say, I doubt that this is a fraudster transaction. So what jam trinity that you talked about, Dr. Pankaj, has put the citizen in center of the control of his own data, of her own data, and see the magic that has done to the payments industry. So, credit card transactions cost almost 1.52%. Aadhaar transaction, or not Aadhaar, sorry, UPI transactions are free, essentially, right?
No. Yes.
So India needs this, both on the citizen centricity point of view, as well as from the lowering of the cost point of view. Now, let's come to healthcare, because that is what we are discussing today. So absolutely agree that you may know about my bank account, it won't damage me so much, but if you know deep private details about my healthcare, it could be very damaging to me, right? I may not want to reveal it even to my close friends. So we have to be very thoughtful of how we build that. And having learned from the trust building mechanisms that were deployed successfully in UPI, UHI and ABDM is also deploying that. And in a sense, the nutshell of that is the citizen gets to have his data accessible to the citizen through technology, anytime, anywhere, 24/7, on one hand of the equation. On the other hand of the equation, through a consent manager, which is an automated system. Consent manager is not a human being, but through a consent manager, the citizen can authorize a doctor, an insurance company, a hospital, or a pharmacy to see all or some part of that data, right? So the citizen can tomorrow say, no, I don't like Dr. Bakshi anymore. I don't want to see him. I withdraw consent from Dr. Bakshi seeing my data. And Dr. Bakshi can't see the citizen's data anymore. So I think that is the central piece of ABDM, which is very important. There is noise that, oh, this is surveillance, this is the government trying to snoop in. The reality is it's an open architecture which has been published. There is no mechanism by which any government agency can read, because the government is not even in the flow of the data. Actually, NHA, which is building the technology stack, is just the tech stack with no ability to read the encrypted data. That is not accessible to any government agency. It is only the citizen, the consent manager, and the authorized person to whom the citizen has given the consent. So I think it's good that you asked this question, because there is a lot of lack of clarity, and it's important that everybody understands that. I mean, the government has seen the magic of how transformative UPI has been, and therefore it wants to have the similar magic, particularly given COVID, particularly given the deep struggles that all citizens have gone through, that we should now use this as a leapfrog into the digital health ecosystem that nobody else has built successfully for various reasons, and we think we can build it.
Okay. So let us take a step back now, so we now probably understand what the ecosystem is talking about. We know that probably it won't be an invasion of privacy per se. We can actually build consent at different levels. But let us take a step back. So it has to be citizen-centric, and that is what we are talking about, right? So the whole purpose of this exercise should be that it has to be citizen-centric. With Ayushman Bharat, we were actually trying to focus on below poverty line, right? So that was the whole idea. And if you actually look at rural population also, do you really see that digitally these population which we are targeting, would it be helpful to these people?
Yeah.
There would be a different level of challenge, because I don't think so that kind of telephonic penetration has been there. Or do you foresee this at PHC level, right? So at primary healthcare center level, do you see that this mission would be able to penetrate so deep that it can actually target our main audience here? Because I think that has always been the bone of contention.
No, it's again a good point, but I want to clarify something very important, Dr. Pankaj. I'm glad you asked it this way. Ayushman Bharat's scheme, the PMJ scheme, the insurance scheme which is run by the NHA, is absolutely targeted towards the below poverty line. There is this 500 million cohort of people, citizens who have been identified through some socio-economic indicators who are now eligible for that scheme, right?
Right.
So Ayushman Bharat digital mission is for the entire country. It is not targeted for the below poverty. It will help the below poverty, and I'll come to the question that you're asking. But I want to make this very important distinction that ABDM, the digital mission, actually is designed for the richest person in Bangalore, to the middle class person in Patna, to the poorest farmer deep inside a district, right? And that is part of the challenge. That how do you design something that is so flexible and so adaptable to have people with different technologies and different skill sets and different literacy levels to still be able to use it, right? And I'll try to give some examples of how this will benefit some of these different segments. But I think that's a very important distinction to keep in mind, that let's not confuse the PMJ scheme with the ABDM mission. That is the narrower below poverty line insurance scheme. It's a social insurance scheme. This is a national digital mission which supports every individual in the country. Okay. So now let's start with the below poverty line, because I think that your question is a very valid one. Not everything needs a smartphone. Let us give a simple example of, say, a patient on a tuberculosis program. The government has this national TV program. It's worth, I think the government spent upwards of 6,000-7,000 crores, if I remember my numbers correctly. That's a large amount of money that the government spends. And what does it do with that money? It basically enables citizens who have suspected TB, either they have blood in the sputum or they have some unexplained fever, or their doctor wants them to be tested. Then they can go to a PHC and undertake some TB test, which includes the chest X-ray, which includes the sputum test, and may include a few other blood tests as well. Then if those tests come positive, the citizen can get free ATT drugs, anti-tubercular therapy treatment, right, from the PHC. And to a large part, to a good degree, this works because the Ministry of Health and the national program have put a lot of effort on it. But think of it from a citizen's point of view. He first has to have the knowledge of where he has to go for the test, and then he has to go there, and then he has to have a knowledge of where he can get the medicines. A large amount of PHCs don't have the medicines in supply, and they're out of stock because of supply chain issues. Now, fast forward to a situation which is being talked about, it is not implemented yet, where this citizen is enrolled onto his digital PHR. He gives consent to the government scheme that, yes, I am a TB patient and you can see my data. So please be very careful. I'm mindful of my word. The citizen is giving consent to the government agency, the TB program agency, that when I upload my sputum results, you can see the data. Because why will he do that? Because if he allows the government scheme to see the data and the sputum comes positive, then automatically he can get an e-rupee coupon to say that, okay, now you can take this coupon and buy the rifampicin and the isoniazid from any pharmacy, which will accept this coupon. Okay. And think of the convenience to that citizen. He's sitting in some village. His local practitioner said, you need this test. He got the test which came positive. He gave the consent, and voila, magically an e-rupee coupon came in his account, which he can redeem in a pharmacy in his village. Now, two benefits of this. One is you have converted a push system, and as a health system thinker, you will understand the supply chain systems, which are push systems, are always inefficient because you don't know who's the end user. You have converted that into a pull system. Those who are positive for TB will automatically get the coupon and can automatically go and buy at their convenience. And by the way, the same idea can be put on vaccination for children. It can be put on malaria programs. There's so many programs, right? So, and these are the exact patients that you're talking about, the base of the pyramid, the ones who don't have that awareness. And by the way, even if the patient doesn't have his own phone, his ASHA worker certainly has a phone. And every village has an ASHA worker now. The ASHA worker can be the coordinator for this patient to say, okay, I know that these 3 people in my village are TB positive. He can upload the sputum results. He can get those e-rupee coupons and get them redeemed on behalf of these individuals who don't have phones. So think of the magic that can do. And this is not theory that I'm talking. There is advanced discussion on this with the Ministry of Health, with the TB programs. And you know that Mr. R. Sharma, who's the head of NHA, has also been instrumental in building up COVID. And actually, COVID has done magic in distribution of COVID vaccines.
Yes.
Now, the natural question to ask is, if we can do that with COVID vaccine, why can't we do that with UIP, the Universal Immunization Program? There are 25 million babies born in India every year, and they should get their BCG, they should get their DPT, and there's a whole range of things that they should get. How can we enable these children? And there are at least, a large number of districts which have not yet reached 100% vaccination. And they're not able to do it because of the push system. They don't know where these babies are born. The program of the district doesn't know where these babies are born. And now imagine flipping that whole switch to a pull system where a baby who's delivered in even a sub-center, I'm not even talking about a PHC, gets registered onto this with the consent of the mother, that only the immunization data, whenever there is a trigger point, I'm happy to receive some funding so that I can go and get this vaccine from a local pharmacy, right? So again, this is early days. I'm just saying that we have seen magic happen in front of our eyes with COVID, the whole COVID application. And how is that COVID application so successful? Because it was an open API. Apollo Hospital could put its availability, local district hospital could put its availability, a government dispensary could put its availability. As a citizen, I could go and see, I want a paid option, I want a free option. If I want a free option, what are the locations near me? And what are their availabilities? And by the way, this is the appointment slot I want to book. We have seen that happen.
Yes.
Of 100 crores. So why can that not happen with a newborn baby or a pregnant mother or a TB patient or a malaria patient? Exactly the same system can be put. And that is the one version of the ABDM, which is, in my mind, a transformational version for public health. And I can see you're smiling because I know you have also looked at these problems from so many angles.
Why I was smiling was mother is the necessity of all inventions. No? So probably COVID just thrust it upon us, and COVID was so that is.
Now, why has Omicron been such a mild hit to our country? Because of the immense effort of the COVID team and of course all the healthcare workers to immunize a large number of the people. So we have already got the immunity. And actually, if you talk to hospitals, yes, there are a lot of people getting infected, but not many are getting into the ICUs, and very few are getting onto ventilators, and hardly any mortality, right? So this is the benefit of that mother as a necessity, that we were pushed into a corner and we responded very well, right, as a country, both public sector as well as private sector. And now the question comes, why can we not do the same to these, 60-year-old problems which have been improving slowly, but they are improving too slowly. And there is a need for rapid acceleration and the same sense of urgency that was given to COVID. Why can that not be brought to these 25 million newborns?
True. Okay, so I think now we have got the vision of the government with this digital mission. We have we have understood that how it can actually help citizens, and consent being a very important part. So yeah. I'm hoping that consent at every level, or probably withdrawal of consent, would be there. So if that is the case, probably some of the issues would be taken care of.
Right? Can you, if you allow me, I want to actually talk about that, because what we have said is a citizen at the base of the pyramid who is also a beneficiary of many of these government schemes. But a large number of India, maybe 800 million people, don't need or don't want any benefits, right? So what happens to them? It's important that we understand that also. So what happens to them is that, and what are the benefits to them in this whole ecosystem? That was your initial question. The benefit to them, which is transformational again, is that every citizen can now have a digital copy of his health data. If I have gone to Lal's Path Lab, and Lal's Path Lab today gives me a printout as well as an email, I just request Lal's Path Lab that please deposit this on my health account as well. And actually that is called ABHA, Ayushman Bharat Health Account. So please deposit this in my ABHA account. Then it is in their server, but it is linked to Ajay Bakshi's ABHA account. And likewise, if I had some cholecystectomy in one hospital, if I had something else, and this is all private sector, or this could even be government sector. It could be PGI Chandigarh. I can even tell PGI Chandigarh that please deposit my discharge summary into my ABHA account. Okay. Now, that is one side of the story. Now, the benefit to me is that no matter where I am in the country, in fact, no matter where I am in the world, I can pull all of these records in front of Dr. Pankaj in case I'm, consulting with you that I have a back pain, and I say, no, sir, my MRI is in Bangalore, but my, EEG was done and that was there somewhere in Calcutta. And by the way, here is a piece of paper which has some details. So that is a typical story in India, right? So now, as a citizen, I can say, sir, you just ask me for permission, I will give you permission, and then magically you can see all the data. And again, this is not science fiction. This is happening in other areas, in railway bookings, in hotel bookings, in even you have heard of bus bookings. So these features are there in other sectors. Why are they not there in healthcare? So now here there is no government. There is the Lal Lab. There is the Max Hospital. There may be a PGI Chandigarh. PGI Chandigarh is also working as a government funded, but as a private institute, which is dealing with a citizen who's saying, please give me my copy of my reports in my Aadhaar account and put them there. So I think that is the other transformational piece that I wanted to bring to it.
So now a little bit up from the healthcare provider perspective, right? So probably few hospitals, few labs, they'll be very keen to get onto this, right? But there would be few hospitals who would feel that why should we share our data? If we share it, maybe we'll lose our patients, our customer base, our client base. So that also might be a challenge. So there are two questions here. One is how to get on board on this health mission. That is one thing. The second thing is, do you foresee these interoperable challenges? Because few hospitals might be very protective about their patients or about their data.
Yeah,
that can happen.
I want to dive into your phrase, our data. The data is not of the hospital, it is of the citizen.
But at least that feeling might be there.
Sorry? That feeling might be there, but that is exactly what the PDP bill is for. The PDP bill is to establish the framework, which is the framework that I talked about, the 4 models of data around the world, and the Indian model is citizen-centric. So the PDP bill is designed to actually institutionalize that, right? And it's still in draft and it is still in the parliament. There is a lot of discussion going on. So I don't know what the final bill will be approved by the parliament, but I do know that the intention is to get away from that confusion that I am the CEO of a hospital and I think this is my data. I'm sorry that is not the case, because I'm also a citizen. And as a citizen, I have a right to ask you to share it with whoever I tell you to share it. You can say that, look, I don't have the infrastructure to share it. And I don't have the money to, be 24/7 server, which is available and which can answer an API call whenever it hits my server. That is and by the way, many doctors don't have that feature. And that is something that also this ecosystem is evolving, that how will there be these technology companies which can enable even small clinics or small doctors with small clinics to be able to answer that question that Dr. Pankaj is in, Dr. Ajay Bakshi's clinic in Udaipur. And he says, sir, please put this in my Aadhaar account. And Dr. Bakshi shouldn't say that, no, I don't have any technology. Dr. Bakshi should say, okay, I'll just press this button on my phone and you tell me what is your Aadhaar number, and then it will be linked. It is all a linking. That is all that is there over there. So your point is well taken. But I would also I would, and we had that discussion last time when I was on this platform, that actually that hospital which is shy of sharing its data is being wrong in its strategy, because they don't realize that by opening their ecosystem, they will dramatically cut their marketing costs. Why? Because one of the biggest problems of hospital is, where do I get more patients from? And they have to have marketing departments and they have to have people talking, branding, all those things. Once you have a national health facility registry and once you have this registry searchable by citizens, then just the way on a Google Maps I can search, or on a COVID on an app I could search which are the options for me to get COVID vaccine, public, private, how many kilometers away and at what price. Imagine then COVID is doing the advertising for you, or the COVID equivalent, or whatever is the app that ABDM launches, that is doing the advertising for you, and that is making you available to a patient who is in a 5-6 kilometer radius to say that, yes, here is a hospital and here are the facilities that the hospital does. So how is the hospital loser in that? Hospital is a huge gainer in that, because it is sharing trusted information which citizens can trust because it is coming through a official facility registry. And no, you and me can't open a small quack shop and say, oh, we are also hospital. There will be a process which has already been put in place by NHA as well as by state governments to say what will it take for a facility to come onto the facility registry, right?
Okay.
So it is actually a huge victory for the hospital also. So the biggest mistake that people have made around the world is that this is my data, I won't share it. Data is one of those things which actually the value of data grows the more people are able to use it, right? And the fundamental unlocking of data value happens when you give the control to the right person, and the right person in this case is the citizen. It is my body, it is my data. Yes, I've used your lab machine or I've used your MRI machine to generate that image, but I paid for it. It belongs to me. It doesn't belong to a radiology machine guy or to the lab guy. There should be no discrepancy in that thinking.
Okay, so I think now from the hospital point of view also it makes a lot of sense after this discussion. So probably we've spoken a little bit about being this as citizen centric. We have spoken this about from the hospital's perspectives. I think the last thing which probably I would like to know from you would be that it's a cost. It's a cost to somebody, right? So you were talking about that, and it's an indirect cost, right? So how would it actually affect the dynamics of this cost per se to the user?
Yeah.
So how would it affect the user per se? Because you're trying to build a huge system here, huge digital system.
So the beauty of digital is that actually it is the cost killer in so many ways. And I can give you 4 or 5 examples right off the bat. If I'm running a MRI machine, I have to either give a print MRI film to the patient, or nowadays some of them have started giving some form of CDs. Okay, because the film is expensive. That's a cost. Now, in my IT system, in my GE or Siemens console, that image is a digital image. And if you come to me with an ABHA account, that's a please transfer this image to my ABHA account, and I have a 100 GB drive linked to my ABHA account. For you, it is almost 1% of the cost of the film to hit a button, and that MRI film gets, or the images of the MRI as well as the report gets transferred to my drive, my GB drive, 100 GB drive. Okay, so you have killed the printing cost, the filming cost, the paper cost. You have made it environment friendly. So that's just one example. We were talking about health insurance, that the cost of processing a claim is 600 rupees. Why is it 600 rupees? Because the hospital is sending a printed discharge summary with English written on it. And the insurance company has to hire people who sit and decipher it. That, okay, this was a cesarean section, this was a normal delivery, this was a cesarean section, was there an indication which was hypertension, eclampsia, whatever, right? Now, in a digitized world, there are standards that the government has already published. These are based on international standards like SNOMED, like FHIR, which will, if you are a participant hospital and a participant insurers in this ABDM scheme, you will send this in that code, which is standardized, and the insurer will receive it in that code. So guess what you have done? You have eliminated a couple of $100 from that because you have eliminated a need for a human being to sit and read. Something that is already in a digital format in a hospital gets converted to paper, goes in paper to the insurer, then that's converted back into digital. And there's a lot of miscommunication in between, and of course a lot of delay, and also a lot of confusion, because there can be typing errors. If you have just plugged in the same standards which the hospital will generate, that no matter whether it is a TKR or an arthroplasty or a knee replacement, it has the same SNOMED code, right? And the insurer knows that if this SNOMED code is there, then a knee replacement has been done. And there is a lookup table which says the knee replacement in this hospital for this scheme is X thousand rupees. So you don't need a human judgment there anymore. Right? Right now, at every step you need a human judgment. And actually that 600 rupee cost is killing the OPD insurance. There is no OPD insurance, which is what actually customers want. I mean, I may get admitted once in 5 years, but I need an outpatient at least 3-4 times a year.
Okay. So as the uptake increases, probably the cost should come down.
I would say even in the beginning, the cost will come down because we don't realize the hidden inefficiencies of the current paper-based system. And I'm not even talking about the cost of mistakes that are made because the patient has forgotten his reports and he has not shown them to the doctor. The doctor did not know that the patient was a diabetic and he's given some tablet, sugar has increased, the patient forgot to tell. What is the cost of that, right? It's not just paper and pen that we're talking about. It is the healthcare cost. Mistakes that were made because, 3 doctors are seeing the patient and all 3 of them don't know what the other guy is doing because the patient never brings all the papers together. And by the way, even if he brings all the paper together, no doctor has the time to sit and read. On the ABDM app, the doctor will have a clear vision of what doctor 1 is doing, what doctor 2 is doing, what doctor 3 is doing. And guess what? There are now software available which can also tell what are the interactions between these drugs. That if you're on clopidogrel, be very careful when somebody is also putting you on a phenytoin because the two interact. And the clopidogrel is put by the cardiologist, the phenytoin is put by the neurologist. And both of them don't know. But the software will tell you that, look, clopidogrel bleeding increases when phenytoin is given. What is the cost of those mistakes? Those mistakes are happening today because we are in a digital world and we don't know. The patients themselves don't know what all to show to the doctor, or the doctor doesn't have the time. And I think a lot of those things will get sorted out once we go full digital on this one.
Okay. So I think we have covered most of the misconceptions here. We have understood the ecosystem. There are quick questions which I have, and this is more on the usage side of things. So, so how to join this mission? If somebody is interested, some private hospital.
Yes. So there is a open community that has been. So there are 2-3 ways to do it. One is the tech folks. So the tech folks who want to build, who want to write code, who want to contribute to the architecture. There is a full community on GitHub called DHP, Distributed Health Protocols. And I'll request Anvesha that she can also put that link in this YouTube video at a later date. I can share the link with you. It's there on Google. If you just do a search for Google, you will find that link. That will enable the techies of the world, of India, to go there and contribute. Because this is, again, as I said earlier, this is a community that has been conceived of by the NHA and the Health Ministry, but for participation from all techies. But guess what? Most doctors are not techies, right? I'm a rare doctor who's moved from healthcare delivery to being a tech entrepreneur. So the way most doctors, nurses, pharmacists, even hospital managements can contribute is to, at least at a conceptual level, understand what are the building blocks. And we talked about some of those building blocks: the building block of health professional registry, the building block of facility registry, the building blocks of payment systems, the building blocks of data and digital PHR, consent approved digital PHR. So what we would like to do is invite all these doctors, nurses, pharmacists, hospital CEOs to come and say, okay, now what can you do with this? How can you make the life of your customer better? There are so many ideas. And that's what I meant in the beginning when I said that we are at the beginning of this journey. There are so many ideas which nobody has thought of right now. So this is an invitation to the entire healthcare ecosystem to say, okay, here are the building blocks. Here is the digital good that is being constructed. So the techies can, of course, contribute to the building of that public good, but the domain experts can say, hey, we can do this and we can do that.
Okay. Okay. And then I have one of the questions which says, which are the easiest and quickest ways to use ABDM related health services by citizens? Quickest and easiest ways.
See, health ID creation is already available. So even Paytm has it. If you have a Paytm app, you can go there and make your own health account. But then you will say, so what do I do with that health account? Now, that ecosystem where more and more labs, more and more hospitals, where citizens go, also have that technology to upload those accounts and link their data to your Abha account, it will take some months and years to build up, because that was your question, how can others participate? So I think it's a chicken and egg. It's a platform where you need enough people who can feed data in and enough people who can use data. So that ecosystem will take 2-3 years. But the start of the journey is that become more digitally aware, and wherever you can cut analog data, you will lose nothing. You will gain a lot, because you will cut a lot of cost, and you will cut a lot of errors that creep in with analog data. And we as a country have learned how to deal with digital data thanks to UPI. All of us have UPI apps. All of us know that, okay, I have, within 5 minutes I have to go and approve this transaction, otherwise my money won't reach the vendor from whom I'm buying something. So similar workflows are being developed for UHI and ABDM as well. And I think the more people that participate in it, the better the results will start to come out.
Right. So I think, thank you, Dr. Ajay. I think we have been able to clear a lot of questions, a lot of queries here. And so I'll hand over the stage back to Anvesha now, and probably she can take it up from there. But it was a pleasure interacting with you.
Thank you.
And
You asked some good questions. And
it was really an eye-opener. Thank you so much.
It was a pleasure listening to both of you and the way this entire session was conducted. So let me just give you a formal vote of thanks. I just want to thank all of you for joining our session today. And it has been such an honor to hear Dr. Bakshi here on this platform again. Many thanks to you, sir, and to Dr. Talreja for moderating this session today. Thank you on behalf of the entire Nat Health team for leading the discussions here. I would also like to express my gratitude to all the participants of the session and the entire NHA team. In case you were not able to answer your questions today, please be rest assured that all your questions will be answered on our blog, nathealthseries.com, and you can always write your question in the comment section and we'll try to get back to you. Please stay tuned for more information and keep reading more about all our webinar series and on our blog, nathealthseries.com, and you can watch all our videos also on our YouTube channel. Please don't forget to like and subscribe us. We will be back again next week on February 4th, Friday at 4 p.m. to cover another aspect of the Ayushman Bharat digital mission with Dr. Kiran Anand Pillai from NHA, and he will be educating us on how can integrators leverage and use ABDM. Till then, bye-bye and take care. Thank you again.
Thank you.